All right. Well, welcome everybody. It's great to see you. Looking forward to this exciting conversation with Karen and Sedona. And we're expecting to go for about 90 minutes. We understand if you have to go early, we're going to record this and then put it on the website. So if you have any questions, and then throughout, because we're such a small group today, if you have questions at any point, maybe just raise your hand in the reactions or put something in the chat and we'll look at it and try to answer your questions the best we can. But it's just great to see all of you. It is a bright sunny day here in Seattle, so just exciting. We lap these days up when we have them here in the Northwest. So loving it. Very excited to just have Karen Pugliese with us and Sedona Montalongo. And I'm going to just begin us in a short prayer and then I'll hand it over to the two of them. And then we also have Margaret, who is just absolutely our support system. And I think most of you know her. So just welcome. If you're just joining us, maybe in the chat room, just tell us where you're coming from and we'll get started. So let's just take a moment to really bring ourselves into this conversation and this opportunity to be together, recognizing that our days are busy and maybe putting everything aside that we just came running from and give each other the time and space to have this conversation. And again, just a huge thank you to Karen and Sedona. So, dear God, spring is a metaphor for change. Some changes we eagerly await, and some we abhor. Some changes we plan, and others arrive uninvited. To all these changes, we ask the gift of your perspective, beckoning us to expectation, hope, and rebirth. May the sunlight and the rain be reminders that you are at work renewing the earth. As a God of renewal, you are ever at work in our lives. Open our eyes and lives to the needed changes in our lives this spring. Awaken us to new life and perspective. For we pray in Jesus' name. Amen. And that is a prayer. If you go onto the CHA website, that's there. It's their spring prayer. So again, I'm just going to hand it over to Karen and Sedona. And just really quick, I didn't introduce myself, but I think I know all of you. Erica Cohen-Moore, Executive Director for NACC, and just grateful to have you here. So I will send it over to Karen and Sedona.
Thank you, Erica. So a pleasure to be here with you. Karen and I are very excited to have you with us this morning or afternoon, depending on where you're at. Again, I'm Sedona Montalongo, and I am living currently in Scottsdale, Arizona, worked at Dignity Health in Phoenix, and currently I'm working for a brand new company helping start a palliative care clinic. It's called Palliative and Pain Associates. So that's brand new, just starting that. Been advanced practice certified since 2014. And that's who I am. So I'll pass it over to Karen and she can introduce herself.
And I'm Karen Pugliese, and I live in Wheaton, Illinois, and I work in Winfield, Illinois at Northwestern Medicine's Central DuPage Hospital. I've been here 21 years and with the Wheaton Franciscan system before that. I've been board certified since I'm a grandmother in this organization since 1983. So, and then I forget what year I was certified in palliative, not that long ago. I just had so probably 7 or 8 years. Yeah. But been with the organization a long time, worked with Sedona for a long time, and we're really happy to share our experience with palliative with all of you.
Yes. So the way that we are going to approach this webinar is, excuse me, we're going to go through each one of the competencies. Each slide has a competency on it, and then we will discuss it. And we really invite you to ask questions, if it's through the chat line or if you want to raise your hand. Our hope is that this is very conversational, because the best way for you to learn is by asking questions in real time. So we are open to that. And then we will also have question and answers at the end to help clarify anything that perhaps you didn't understand or you just need more information on. also want to start with the history of palliative care and hospice advanced practice certification. For short, we call it PCHAC. So in, I want to say 2017, NACC and APC wanted to join forces and become partners in the advanced practice certification process because we were both doing the same thing. And we thought, why are we both working so hard separately? Let's put this together. So we got together over a weekend and we whittled through the original, back in my day, 32 competencies that we had to demonstrate proficiency on, down to 14. So aren't you all lucky? The kicker is that one must demonstrate proficiency in all 14 to become certified. So you have to have proven that you are good in all of them. If you miss one, then you will not be successful, but we highly encourage you to come back. So that's really important to know that the 14 are the most important that we have. One of the questions that we get often is, I work in end-of-life care, and so why can't I become a PCHAC? What makes you different than me? And you're going to learn more about that throughout our webinar this morning, and we'll get more into that. But that is a very common question that we get, and we hope you are able to answer that question at the end of this webinar as well. Are you on a team? Are you integrated? Listen as you're going through this webinar to the skill set that you need to become advanced practiced. What Karen and I really want you to hear is that the PCHAC and the generalist chaplain are both equally important. One is not better than the other. So we in no way want to diminish a generalist chaplain versus a PCHAC. It's just a different skill set. And hopefully in the future, there will be other specialty certifications, perhaps behavioral health, and other ones brewing underneath. So we don't want you to leave thinking that one is better than the other. They're both needed and both excellent. So that's important for a takeaway for us, for you.
And it's interesting. I think a lot of people don't know this because it was so long ago, but in the 1990s or late 80s, NACC had advanced practice in rehabilitation medicine. And I was certified as an advanced practice chaplain in rehabilitation medicine. And after a while, it just went away because people there wasn't enough interest. People didn't want to do all that work, and nobody else was doing it in the other organizations. So it's nice to know that we were kind of pioneers, and we're coming back to that, hopefully expanding the advanced practice concept.
All right, next slide, Erica.
So this slide, some of you may recognize these stone sculptures by this beautiful little lake. These are called cairns, and they are created by people on a journey, on a pilgrimage. And as they go along their way, they leave a stone marking the spot where they were and marking the intent of their journey. And it's also a means of hospitality and wayfinding for those who will continue on the journey. So we are creating cairns for you to come along with us on today's journey. And we will complete our journey and celebrate it when we come to the end of our presentation.
All right, diving right in. Competency number 1. Integrate the history of the hospice movement and the subsequent development of palliative care, while differentiating between the current philosophy and goals of palliative care and hospice in practice. So something that Karen and I want you to think about when you're reading these competencies is to read the competency 3 times. The first time you just read it and go, okay. Second time, you're taking it in a little bit better. And by the third time, you're really hopefully really understanding what they're asking. Okay, there are a lot of times when applicants or people interested in applying don't read the full question. And so they're not doing themselves service by only answering part of the question. So this is an integration question. It's on the history of the hospice movement and what's the difference between palliative care and hospice? And this is a really important question. And there's a method behind this madness of why the heck do I need to know the history of palliative care and hospice? I don't need to know any of that in BCC. Why do I need to know that in palliative care and hospice? And the reason really boils down to this. When you're at the bedside and somebody, either patient or a family member, learns or is the term palliative care is brought up, 99.9% of the time, still to this day, what does the patient or family think? I'm going into hospice care. I'm not ready for that. Even physicians will say, when palliative care is brought up from physician to physician or chaplain to physician or whomever, could this patient be appropriate for palliative care? Even a physician will say, oh, no, she's not ready for that. Okay, so part of this competency is asking the chaplain to know and be able to articulate to that family member or that patient to say, oh my gosh, you might be thinking that palliative care is hospice. Let me share with you and explain to you what the difference is so that you are more comfortable in making the decision on if you feel that it is appropriate for you to go into palliative care and have palliative care as an extra layer of support for you. So that's one of the methods of the madness, is to know the difference between palliative care and hospice. Now, if you are choosing to apply for this certification, the application isn't asking for each detail of the hospice movement, but you must know the basics of how it started, who's Dame Cicely Saunders, how did she begin the hospice movement, how did palliative care grow from the hospice movement, and just a basic understanding of what it is. But the real crux of it is to know the difference between palliative care and hospice and to be able to articulate that easily and smoothly and seamlessly to your patients and families. One of the other things that is important to consider is your role of the spiritual care in palliative care and how is it different in hospice? Because they can be. A lot can be the same, but there are also differences between palliative care and hospice and the role of spirituality in those two organizations. All right.
So competency 2 really focuses on familiarity with state and federal laws regarding end of life. So we really expect that you will understand what those laws are, where you work, and where you live as well. As board certified chaplains with so many responsibilities and often few resources, for example, with the typical silos that we work in the typical medical care setting, chaplains sometimes tend to leave the end of life conversations and advanced care planning to social workers or care coordinators. However, in palliative care and hospice, it's really important to have the conversations, to partner and collaborate with our team members. You're going to hear us say team, team, team 100 times today, because it is team. And so the team discusses and addresses critical issues that are related to state and federal laws regarding end of life. Issues like surrogacy, medical decision-making, advanced directives, decisional capacity and competency. So advanced practice board certified chaplains in hospice and palliative care need to be able to use simple but important tools to assess decision-making capability, They're not the only ones who do that, but we need to do that from our perspective as the spiritual care provider, and then enter into conversation with the rest of the team, and then assist the team to understand how we understand the patient's ability to do that and what other dynamics might be present in the situation. And then assist the team sometimes to work with the surrogate decision makers to make choices that are congruent with the patient's values, not their own values. And then also to assist with the determination of competency, whether the patient is competent to make their own decisions at this point. Sometimes people wait so long and then it's too late. So when you come before the certification team, what we're going to want to see and hear from you is how you explore and address religious and cultural issues. How do you function as a team member in addressing requests for things like assisted death, organ procurement, brain death, and things like we trust there's going to be a miracle, so we don't want to talk about all those other things. So it will be important for you to be in touch with your comfort level with legal issues, and then to be able to give examples of how you navigate issues, like the necessary elements that should be included in a capacity assessment. Sometimes it's required to have a psychologist or a psychiatrist to make the end decision, but it's important that you're included in that because you bring important information to that as well. So it's in your capacity assessment, you need a tool like the capacity to understand relevant information, the understanding whether the patient has the capacity to appreciate the situation, the medical situation he or she is in, and the capacity to appreciate the consequences of that. And then finally, to be able to actually express a choice and the capacity to state a rationale for that choice. So all of those things are related to state and federal laws that are different, even in contiguous states. I was at a conference last week in Wisconsin, and there are different laws regarding the assessment of competency from the laws that are here in Illinois. So it's really important to understand, because families most of the time have no familiarity with that. But it will be important that you not only are familiar with it, but talk about how you function as a team member in addressing those issues. Anything you want to add, Sedona, to that?
I think you did touch on it, but to really familiarize yourself with what brain death is and is not is very important. Assisted medical aid in dying is now becoming more common, and people do bring that up sometimes. And so how do you navigate that? How does your own personal views versus the desires and the views of the patient inform? How do you navigate that situation? So those are very important things that an advanced practice chaplain needs to be comfortable with, but also know the legal bindings around things like brain death. It's different in certain areas, but for the most part, if someone is declared brain dead, they have died. They have a time of death. This is very difficult for patients and families to wrap their head around, because they still see the chest moving. They still look pink. They just look like they're sleeping, right? So it's very challenging. So to understand the ins and outs of these legal matters, a feeding tube is another one. Here in the state of Arizona, there's something called Jesse's Law, which really affects the decision-making behind getting a feeding tube. You'd have to have a court order to remove that if you don't have a medical power of attorney. All those things are very important for us to know.
Yep, good. Okay, we'll move on to competency 3.
Yes, we just got a question. It says, will someone on the certification committee be from the particular state in which the chaplain practices? Sometimes, not always. It just depends. But what's important is for you to know what yours is. Sometimes if you're in New Jersey, there are certain practices in New Jersey and New York because they're so close. You will need to know that. The advanced practice chaplain generally knows bigger areas that there are certain practices, but we expect the chaplain to know the most.
And I would also say that we as a team, when we read your materials, we read and read and read, and we explore those things. We want to know what they are, where you are, so that we can assure that what we hear from you or what we read in your materials is correct. So even though we're not necessarily from that state, we do our due diligence, we do our homework before we come into the actual committee. You're welcome.
Yes. All right, competency number 3, demonstrate an integrated knowledge of the implications of medical treatment for life-threatening or life-limiting illness as it impacts a patient's physical, psychosocial, emotional, and spiritual pain. Again, reading the question over and over again, it's important that you see that it says physical, psychosocial, emotional, and spiritual pain. So all 4 of those need to be addressed in your writing. And so, Karen, we need to remember at the end to talk about how we don't write like BCC, but we write differently. So if Karen and I don't remember, please remind us to talk about that. So this one, many times when I'm mentoring, or even with staff chaplains, generalist chaplains, this comes up a lot.
Yes.
When we talk about this competency, the pushback that I get and the rest of us who are PCHACs get is that's out of my scope of practice, right? And our response is, no, it's not. Now, is there there's a fuzzy line that we don't cross. Okay, we're not administrating or administrating medical advice. We are not doing that. But I, as a professional advanced practice chaplain, I need to know for my own ability to journey with this patient and family, I need to know what this person's treatments are going to be, what this illness might look like going down the road, what to expect in this patient's illness as the trajectory, as it moves down the line. How is it going to impact this person's physical being? How is this illness going to impact their psychosocial, emotional, and spiritual being? And the reason for this is because in palliative care and hospice, but in this instance, I'm going to speak palliative care, it is not a one and done. Many generalist chaplains, they are visiting and it's one and done because that's the nature of their work. In palliative care, it's a journey, right? So I'm going to give an example of a patient named Susie, who I'm just going to use myself. I've met in the palliative care clinic. She has stage 3 breast cancer. She's doing very well. But eventually she ends up going into the hospital and getting admitted more lately than not. She's now diagnosed with stage 4. She's metastasized. And so me knowing at stage 3 what that impact is going to look like for her is really important so that I can begin at stage 3 in the palliative care clinic to start my advanced care planning, because I know this is not going to bode well for her. She's got 3 children. She's got a husband. She's got a family who loves her and takes care of her. So what will this advanced care planning do for her in terms of protecting her autonomy, her wishes, and protect her husband and her children? So getting these documents done earlier rather than later is crucial. So that's because I know the trajectory of this illness. And then how is this going to affect her socially? How is this going to impact her life with her children, getting them to soccer practice, getting them to piano, getting them here, how is this going to affect? And how can I, as a chaplain and perhaps the social worker, help her to navigate these things in a way that's going to be helpful for her and her family? How is it going to affect her emotional and spiritual pain in many, many ways? Is her spiritual pain, does she have negative or positive coping spiritual mechanisms? Not every spiritual coping mechanism is a positive one. There are many negatives. So is that something we need to address? And her emotional pain. So in using Susie as an example, that's one way to think about a patient is in the beginning is how is my information, my knowledge of this person's illness, no matter what it is, going to help me to help her navigate this illness. So do you see how that I'm not using it to inform her in terms of medical condition, but I'm using it to inform myself to help her navigate?
And what begins to surface even in this early stage of the trajectory is how this affects the team. You know, someone on the team who has children that age, who is that age perhaps, and this is very impactful for that patient. So how does the team reconfigure itself so that each person interacts with the patient, but in ways that are healthy for not only the patient and the family, but for the team member too? Good.
Next slide.
We have a question about measuring that. Do we want to talk about measurement right now?
Why don't we come back to that?
Yeah, I think that's good, but thank you for asking. So in competency 4, what we're looking at is, this is one of my favorites, is demonstrating how we utilize family systems theory and how it's incorporated in the practice of palliative care and hospice as applied to the care recipients, the patients, their extended support system, their families, and the healthcare providers. So how do we integrate family systems theory into our team collaboration and also into our spiritual care interventions? So what we will be looking for from you is a discussion of examples in your own experiences with some of the very human dynamics that we all live through, like triangulation is a very common, easy one, but also family system theories. What family system theory do you work out of? What, as you have studied and examined different theories like Murray Bowen's theory, how do you utilize that? And how effective is it for you? And are you continuing to learn as you experience different patients and different trajectories? And how do you lead the team in discussing what might be going on in this family system, and how do we work with that, and what is that triggering in us? And so how do we need to work with each other so that we're able best to support the patient and the family? So when you write your application, we're not looking for a little mini didactic on theory, which when I was certified, I gave a little mini didactic on theory and learned that wasn't what was needed. We want you to really demonstrate what you do, how you've integrated your knowledge of family systems and dynamics into your ministry practice, how you've made it your own, and how what you know really influences what you do. So we'll want to see how your understanding and incorporation of family systems theory into your spiritual care interventions has been helpful in your ministry, not only to the patients and families, but to your colleagues and coworkers. So our role, each member of the team has an important primary role, and then we all have the secondary role, which we're paying attention to all the dynamics, but each of us with a different level of competency for each one of them. And so it's complex. This is why it is different from the board certified chaplain, because there's a different level of complexity in this. And again, not better, just different. And so in Susie's case, how does the team look at her family dynamic? How does the team look at the fact that her husband doesn't come to the hospital very much? Suddenly his work requirements, his work expectations are keeping him away from the hospital. But the grandmothers are bringing the children to the hospital. But then some of the grandmothers or the aunts feel like, well, this one's too young. We shouldn't bring this one to the hospital. It'll be too scary. And it'll be too hard on Susie. So all those dynamics are going on, and the team needs to look at that and then determine what's healthy, what's not healthy, what is affecting Susie positively or negatively, and then determine care planning based on those assessments and then the dynamics that you want to integrate into the team's interventions.
Yeah, and I'd like to add that in some situations, you can hear chaplains and social workers that they clash. And in hospice and palliative care team, hopefully, not always, but for the majority, the teamwork overrides any clashes. And the chaplain and the social worker in a perfect world work like this.
Yes.
So in this situation, and as Karen was talking about Susie, the teamwork and the working together of how they're going to help these kids is a wonderful example of how to blend the spirituality with the emotional piece, the psychosocial piece, to help this family navigate this really difficult illness and to know what's coming down the road, again, the trajectory, to help them cope with what will be coming down the road for them.
Yes, and at some point, does the team discuss bringing in child life? But then one of the grandmothers doesn't want to do that because it'll be too scary, and then they'll know their mom's dying. And the other grandmother says, but I want them to have things to remember. So who takes on this grandmother and who takes on the other grandmother, and how do we work with child life therapists to integrate them into this family, the practice of care for this family as well? Good.
Competency 5, apply culturally appropriate, evidence-informed strategies for addressing the breadth and depth of multifaceted grief, including complicated and anticipatory grief, and to extend it to bereavement resources. I would like to add, it's including, but not only complicated
Yes.
and anticipatory grief. Complicated and anticipatory grief, we all know that, right? We all know it from our BCC. It's very common. We understand that complicated grief it's layered, it's complicated, right? Anticipatory grief, we all pretty much know that as well. We know that the illness is coming or the death is coming. We're anticipating it. And people who have dementia or Alzheimer's, there's a lot of anticipatory grief. There's death before the actual death happens. So we're familiar with those terms. In an advanced practice chaplain, it's important to understand even more types of grief. What are the other ones that are out there? One that I experience quite frequently, and perhaps you do too, is disenfranchised grief.
Yes.
Disenfranchised grief is a grief that is not accepted by society. For example, Johnny is a drug addict. He's been a drug addict all his life. He's now living on the streets. All he wants is drugs. He's got sores all over. He's a very, very, very far down the road in terms of his addiction, and he ODs. And family finds out a week later he has died, and there's shame wrapped around this grief,
Yes.
right? Because he's been an addict. And then family and friends might be thinking, he did it to himself. He could have stopped. He was in the streets. All those things that wrap around what what we can think about someone who has an addiction. Alcohol, he drank himself to death. Well, he could have stopped. A street worker who got raped and killed. Well, she worked in the street. So that's a disenfranchised grief that also needs deep healing and an experienced chaplain to be able to navigate and talk about that as well. So that's multifaceted, right? And so there are other types of grief as well that one needs to know more about and be able to articulate and integrate into conversations. So when we talk about the breadth and the depth, that's what we're talking about. And then those informed strategies. How are you going to navigate this with this patient or with this family? What are the things that you were going to bring forward to help this family navigate this? What about children? For example, with Susie, how are you going to navigate that grief process? And they're different ages. One is 5, one is 10, and one is 12. They navigate death differently. The 5-year-old and the 12-year-old are going to be very different grieving stages. So that is something else that you and the team need to be aware of as you're also visiting and journeying with this family. What about goals of care changes as grief is changing, as the illness, for example, with Susie, she's now stage 4. She's having more pain. Her symptoms are getting worse. And so how are you navigating those goals of care changes that are going to continue to empower her, but you know that they're changing? So maybe her goals at this point are no longer aggressive treatments, but she still wants to try some things, but not fully give up aggressive. She's willing to give up very aggressive treatments, but not willing to give up some of the treatments. So how do you navigate that and change those goals of care? How do you stay informed with the team? How do you converse with the team? And how does the team keep abreast of all of the information that's happening with Susie?
And sometimes Susie is worn out from the pain and the existential angst that she's experiencing, and she just wants to be able to rest. But her family says, don't give her so much sedation. We want her to be awake. We want her to talk to the family and her children. And so you've got conflict like that as well, which may also have some guilt and shame connected to it in terms of family members, and sometimes in terms of the patient themselves. So when we say multifaceted, complicated grief, and disenfranchised grief, it's very, very, there is a breadth and a depth to it.
Yeah, and I think the word that just came into my head as you were talking, Karen, is it's messy, right?
Yes, it's messy.
When there's family, and like Karen was saying, one grandmother wants this, one grandmother wants that, maybe the aunt is, you all know what we're talking about. We're preaching to the choir. We know messy when we see it. But the question is, how do you lean into the mess and help and inform and calm and lean in? So that is something that we are expert communicators. We like to say that advanced practice chaplains are expert communicators. We're expert at diffusing. So we lean in heavily to these types of situations. Karen, we have a question here from Brian. It's, when writing for this particular competency, is it more important to demonstrate knowledge of different types of grief, example, listening to them, or to have different strategies for the ones you identified? Brian, this is a great question.
Yes.
We're going to circle back to this when we talk about how to write for this application. But quickly, you are not going to write to each competency. Please hear Karen and I. You will not write like BCC to each competency. And we're going to come back to that at the end when we tell you how to write to these competencies. You're welcome.
Yep. And it really is much more about storytelling.
Yes.
It's sharing your story of your professional competency in working in palliative medicine or
yes.
hospice care. Yep. Okay. So competency 6. Here we're looking at how you incorporate your working knowledge base. And again, integration. there's a reason why that word is used over and over and over again. Probably the primary theme that each certification team is looking at is how the applicant has integrated all of these skills and competencies into their ministry practice. And so it's not knowledge-based, it's not only knowledge-based, but it's how that knowledge has been what we do with food, how that has become part of your being, how it has fed you and nurtured you and nourished you and has made you a healthier and more competent practicing chaplain. So how you integrate the psychosocial, emotional, and spiritual perspectives so that you can demonstrate effective and expert collaboration with your team and with your patients and their families. So this too is another one of my favorite competencies, because the purpose of this competency is to give us opportunities and to give candidates opportunities to describe the central transdisciplinary distinction in palliative care and hospice practice from that of the equally important interdisciplinary approach used by other clinical teams. So again, one is not better than the other, but they're very different. They function differently in the ICU from the way they function in palliative medicine. So if anyone has a question about transdisciplinary, we can talk about that in a little bit too. But what the certification team will be looking for is what the scope of practice looks like, what your scope of practice looks like as you assess, as you collaborate with the team, as you plan your interventions. And in doing all those things, you are treating the psychosocial, emotional, and spiritual issues that you encounter, like total pain that we've discussed already, like grief, like loss, like the need that surfaced for Susie as she's going further down the road in her trajectory. Does she have a need for life review? Does she have to talk about her marriage? Does she have to talk about giving birth to these children and then leaving them? And some of the feelings and emotions around doing that, her own guilt at leaving them, and perhaps her own unfinishedness in leaving them with her husband or leaving with competing families, her family of origin, his family of origin. And so the chaplain, as a communication expert, as well as an emotional expert, needs to be able to talk to both families, or to decide with the team, you know what, we have to split them up. You take this half of the family and I'll take this half of the family. And hopefully, as we're working with each of those, we can bring them together at the end so that Susie's dying is a good death. So one of the things that's most important in this competency, and we're going to be looking for this, is your role in family conferences. It's a really crucial component of palliative care and hospice practice. So we'll be looking for your story of how you discuss with the team your plans to include patients and families' emotional and spiritual needs as an integral part of the goals of care conversation that happens in family conferences. And then we're looking for you to talk to us about opportunities you had to step up to either facilitate or to offer to assume leadership. Perhaps you have the deepest, longest working relationship with Susie. And so can you offer to be leader in this family conference with this kind of complex family dynamic? And in surfacing and addressing your assessments and interventions with the team, especially as they might relate to current barriers or potential barriers that impact Susie's care. Things like spoken and unspoken emotions, things like conflicts. Why is Susie's husband never coming to the hospital? What's that about? Secrets, things that people haven't shared, but they're holding and that are right under the surface of conversations. And then competing alignments sometimes within a particular family. So we'll also be looking for examples of your leadership, not only as the spiritual care expert provider, but also as the educator of your team and your organization and the wider community. So the scope of this practice, this particular competency, is very broad as well as very deep. And it gives the opportunity for really good storytelling.
Competency 7, demonstrate effective communication and facilitation of goals of care family meetings that align treatment plans with the patient's values and/or advanced care plans. So Karen's talked about some of her favorite competencies. This one is my absolute favorite. And I think well, I know for myself, it's the place where we as advanced practice chaplains can really shine and show and demonstrate our expertise as spiritual care experts. So many times chaplains will be invited into a family meeting if they're not on a team, but they need a chaplain, and they'll say to the floor chaplain or the unit chaplain, can you come into this meeting? And many times what this chaplain does is sits there through the meeting, perhaps notices some tears, might hand a box of tissues, and the physician or the nurse practitioner is sharing the information of the illness, how things have changed, how things are now becoming more difficult. And so, and that there is very little treatment options left. And the chaplain sits there and listens to all of this, but doesn't say anything. And so what is important for the advanced practice chaplain, the difference is that this chaplain deeply leans into the conversation, doesn't hand the tissues, because that's what we think we need to do, but we lean in and we talk about, or we notice perhaps the physician is giving information and you see the eyes glaze over the family. Chaplain notices this and says, excuse me, doctor, can we pause a minute? I'm noticing that there might be some need for clarification. Can we stop? And yes, absolutely. And then the chaplain begins to say, I'm noticing that you're looking a little confused. What is it that we can help to clarify for you? That's how the conversation deepens, right? Oh, well, we really don't understand when he said or she said that there are no more treatments when you just offered us dialysis. So that's confusing, right, to the family and the patient.
Yep.
So then you begin to go, okay, there's where the information and the education needs to take place. The next thing perhaps is you notice the tears. I'm sorry, doctor, can we stop for a moment and just address what might be happening right here? So this is how the chaplain really leans into the goals of care family meeting and helps to remind the family and the care team what was initially important to Susie. So perhaps you might say, when Susie and I filled out her advance directives, she was very clear that she wanted to have aggressive treatments up until the time when the doctor said that there would be no more helpful interventions for her. And I'm wondering, doctor, are we at that point now? Do you see how you're leaning in and you're helping facilitate this conversation? You're asking questions that the family does not know how to ask, or they don't even know is a question, but you do. Why? Because you know the trajectory of this illness. Remember competency number 2, or we talked 3, we talked about how you need to know the trajectory. So you're tying those together because you know. And so you're asking, I like to say, I'm kind of like the dummy in the room. Doctor, can you tell me what that means? Because you're asking for the family and your team knows you know.
Yeah.
So you're helping to facilitate this meeting. You're helping the education piece. You're helping the communication piece. And most importantly, you're helping to ask the questions the family does not know to ask. And you're protecting the patient by saying, this is what Susie had said. And so I'm wondering if we're there yet. Susie had mentioned this. Susie wanted something for her children. Susie, because remember, we always want to make sure that Susie's in the room somehow, and it comes out through your voice. So my favorite competency.
Yep, yep. It's great. Yep. And it leads right into competency 8, I think, because this is all about collaborative and facilitative leadership with the care recipients, and again, with the family, with the team, with your organization. So you're hearing over and over again, leadership, integration, these are key concepts. And so when we said before that there are certain things that are important to this process of certification, not just knowing competencies or being able to say, yes, I can do that competency. It's being able to demonstrate how it lives in you, how you are a leader. And there's no one way to be the leader. It's not one size fits all. It's how you do it in particular circumstances. So it really is a key overarching component of not just this competency, but all of them. So one of the qualities and the significance of the advanced practice palliative and hospice chaplain needs to be demonstrated by each person in their unique setting. It's not one size fits all. And sometimes we hear in certification teams that the chaplain will say, well, I'm not allowed to do this. And so part of your leadership is being skillful and being able to find ways to integrate yourself into, for example, the family meetings where you are doing the things that Sedona just lifted up, that the family can't do, and that the team is focused on other things and would not be able to do. The other piece of that is also you have a unique relationship with the patient and you can bring that back to the team. And that is a way of leadership too, that you're leading the team into a deeper understanding of the patient. So we'll be looking for your unique story of integration with your team. How does the team see you? How do you feel you are a member of the team? But also your organization. How does the organization understand you? And even your healthcare system, as well as your participation in either the hospice community or the palliative care community, and in our profession. So we'll be looking at what choices you've made for continuing education, what ways you've been involved in professional activities, locally, nationally, like NACC or organizations like Transforming Chaplaincy, which leads you to, yes, and LGBTQ, very good, excellent. Yes, that's important to integrate that into this as well. And what research and education opportunities are you involved in? And what organizational or system ethics involvement and education you're a part of. We'll also want to know what your vision and plans for continuing to integrate and educate yourself in your role. And we'll want you to tell us how you talk about the advanced practice role with your spiritual care colleagues, with your palliative care and hospice team. And if your institution has inpatient hospice patients, as mine does, how does the palliative chaplain interact with hospice chaplains and vice versa? In a hospice setting, how does the hospice chaplain interact with the chaplain back in the hospital that's sending the patient to a hospice setting? So all of those are important components of collaborative and facilitative leadership with the broader scope of your practice.
And just quickly, another piece of that is ethics.
Yes.
To know the pillars of ethics, medical ethics, what they are, and how they are used in your work as a chaplain, as a palliative care and hospice chaplain. So, for example, you need to be well versed and able to understand trajectories again. The family wants to put a feeding tube in their 98-year-old mother with advanced dementia. Well, that's medically not appropriate. And it causes more harm. And it does things that, okay, Brian has to jump off. Brian, you can email your question or we will be able to answer how to write to the competencies. But to get into the ethics piece, you need to know how that is not a good idea and to be able to educate the family in terms of putting a feeding tube, for example, in their 98-year-old mother with dementia. And they may come back and say, but the church says.
Mhm.
So again, knowing what the church says about a feeding tube and if it's beneficial or not at end of life. Okay, so we're going to move on, just being cognizant of time. Did we do 8? We didn't do 8. Did we do 8?
I just did 8.
Okay, 9, demonstrate the best practices in palliative care and hospice spiritual assessment and documentation and facilitating aligning patient values and goals with treatment plan.
I think
So-
that'll get a little bit to the measurement question too.
Yeah. So documentation in an advanced skill set, long gone are the days where chaplain prayed at bedside. End of story. Remember back in those days, that's how chaplains used to chart. Now, if you are working on a team, for example, I am always charting to the team because I want them to know what I'm seeing, what I'm hearing from the patient and family in order to best help the team so that when the team reads my notes, they go, oh, I didn't know that. Oh, we need to talk about this in our morning huddle, in our morning meetings. Oh, they never said that to me, because patients and families will share with the chaplain and or the social worker things that they will never tell the physician or the nurse practitioner, right? We know that.
Right.
So, so when I am charting always to the total pain. I'm charting to the social, the physical, the social, the spiritual, and the emotional and cultural and legal areas. So was the patient in pain when I went in? Was the patient appropriately medicated? Was the patient comfortable? Was the patient demonstrating anxiety? Now, we don't say the patient had anxiety, right? We all know that. We say it seemed as though the patient was anxious, or the patient voiced that she was very anxious. So then we chart the how did you deal with that anxiety? What did you do with that anxiety, knowledge of anxiety? What was the outcome of charting to that anxiety, right? You want to chart to the social piece. The patient is very concerned about, Susie's very concerned about her children, how they're going to be raised. She's concerned about their quality of life moving forward after she dies. She's worried that they won't be able to go into soccer practice anymore, whatever she's worried about. She's also worried about finances. She's worried about not being able to pay for her medical bills when she has died. Those are things that are going to pop up, and those are the things that can cause for existential pain that cannot be medicated. All of those worries and concerns can cause deep spiritual and emotional pain. So then you also want to chart on the cultural. Patient is Hispanic, always needs interpreter. Please be sure there's an interpreter present at each meeting. Or the patient's Asian and has cultural medicinal values that need to be considered. Whatever it might be. And then finally, legal. The patient has completed their advanced directives, or patient has not completed advanced directives. Their surrogate decision maker is, because they're no longer able to do it, is their husband or their mother or whoever. So charting to the domains is very important. And if you go through it systematically, it's very helpful. Or you may choose another tool, the spiritual aim, or your charting system only allows for checks in certain areas, but there's a text area where you can text. That's where I would put all that in.
Yep. And I'll just put in a plug for the PC7, which is another way of charting that includes a very helpful, quick visual of a numeric progress, a measurement, speaking of measurement that we mentioned before, as well as the opportunity to write narrative. So the more you can do for your team to simply, but with communicating the whole of the situation as much as possible, the more you can do that for the team, again, the more your leadership will be recognized within the team. So that's very good.
And it's important to always check in with your team to say, hey, how are my notes? Is there anything
Yes.
else that I could do to make them better for you?
Good.
Don't be afraid to check in. And after 6 months, 8 years, hey, how's the notes coming? Are they helping? Always check in, but always ask if they're helpful or not.
Good. So competency 10, we're back to trajectory. So you see that demonstrating how you provide care throughout the trajectory of someone's illness, a life-limiting or life-threatening illness. And to demonstrate that integration, it's really, really helpful to provide, and this gets to the writing, short, well-written, and focused mini case studies. So what we've been doing with Susie here, that describe how you provide ministry as an integrated member of the team for patients with life-limiting and then life-threatening illness. It might be that that's part of the trajectory, or the patient comes in way too late and it's already life-threatening. But how do you tell the story of that short life-threatening illness that results in a death, but across the trajectory of the patient's illness and the family's experience? So one of the things that you might think about too is, how is that different if you were a hospice chaplain or you were a palliative chaplain? And how do you understand your role? And how do you understand the trajectory of illness as a palliative chaplain, as distinct from what a hospice chaplain might see? And then talk about your experience and your understanding of best practices, the practices that you have found best in collaboration with your team and in ongoing study, so that you show how you understand the similarities and the differences in different people's way of practicing, people who use the AIM assessment and people who use the PC7, the difference between hospice chaplain and palliative chaplain, your own experience of that, not just a definition of what that might look like.
11, demonstrate knowledge and skill in addressing the ethical dilemmas at end of life and concerns as related to spiritual and or religious issues. Touched on this already with the 98-year-old woman who has advanced dementia and family is considering a feeding tube. That's an ethical dilemma. And one that needs to be processed. And many times there are religious issues wrapped around that, or cultural issues. I'm going to starve my mother. You know, that's a common phrase or dilemma that comes up. I have to feed her. She's going to starve. So it's important to understand what mama needs at that point at end of life, and to understand the medical issues around what happens when we force feed someone at end of life. They begin to swell, they get edema, they can't process the food, it causes more pain. There are many things that happen at end of life when we force feed. You need to know those kinds of things so that you can gently and appropriately have this discussion with the family. That is not out of your scope of practice. It's part of your educational, it's part of your skill set, especially when religious or cultural issues come into play. So here's another thing, is knowing when something is a true ethical dilemma or is it just a really messy case.
Yes.
Sometimes that happens where families get labeled, they're disagreeable, they're
Difficult.
they're difficult, when in reality, many times it's a communication issue, right? So that's when that's when they will call in palliative care. I'm not using a hospice example at this point, but in palliative care, that's when they'll call us in because we're the communication experts and can you please deal with this? When in reality, it's not a true ethical dilemma, but it is a messy family. So we need to know the difference between those two things. And then if it is an ethical dilemma, what method do you use to discern how to go through to figure out if it's an ethical dilemma? I personally like the 4-box method. It gives me a lot of information that I'm able to ask and really figure out, is this truly a dilemma? So there are a lot of dilemmas that we face in palliative care. There are, brain death issues, there's neurological issues, the cancer, aggressive care, fetal care, all kinds that we are going to bump into. So it's very important to be well-versed in ethical issues and how you, if you sit on an ethical,
Consult.
thank you, how you're present in that and how are you leaning into that? How's your voice being heard? Because you want to be able to make a difference.
Good, good. And there's lots of material available to read, research to read around ethics. So there's, make those things available to yourself for your own growth. Yep. So competency 12, we're going to switch gears a little bit to focus on the breadth and scope of your experience of evidence-informed practices. You're going to hear those three words too a lot, but related to the well-being of the care team, the palliative team, and the organization staff. So that's kind of, people look to us for that. And so we're going to be looking for you to share your experience of advocating for and collaborating with nurses, physicians, social workers, and how you're promoting the well-being of those in your care. So we're finding here in our organization that nurses, but also some, particularly nurses, are being drawn to do self-care kinds of activities, even mindfulness, to get mindfulness certification, because it's a lot easier than being on the floor, and it's a lot more fun than being on the floor. And so some of what has been our role is also being acquired by other disciplines. But it's important for us to claim what our competence and our what is ours to do. So we'll look for examples too of self-care and the well-being, not only of the team, but you as a member of that team. Think about some of the specific issues that you've recognized and responded to. Moral distress, when someone is asked to do something that's against their own values and principles. Burnout, when they're exhausted after 16-hour shifts and going home to a new baby who's got colic and who has just had a case of RSV, and then post-traumatic stress, which is very, very present in the medical world right now. So even if it's not officially part of your responsibilities, how have you navigated both spoken and unspoken, recognized and unrecognized by the organization's needs? Sometimes we find that organizations feel that the way to take care of distress, spiritual distress, emotional distress, physical distress, is to bring candy, around to the units, and to do fun activities or to do stretching during breaks, which are not bad things, but they don't get to the deeper core issues. And as much as nurses like to do the physical activities, sometimes they don't have the skills or the ability to get down to the deeper counseling issues that we can provide for our team. But we can only do that if we're well ourselves.
Competency 13, demonstrate the ability to teach and educate through articulating and integrating current research on best practices for the provision of palliative care and hospice chaplaincy care. Basically, folks, how are you keeping current? What are you reading? And how are you taking all the things that you're learning and you're reading and putting it into practice? That's really what we want to know, is keeping current. We can get stagnant. We've all been around chaplains who are stagnant, haven't we? We know when they are just not happy anymore. We're tired. We're grumpy. So we want to avoid that through our self-care, like Karen was talking about. But we also can get invigorated by learning more and educating and trying new things. There's thankfully so much more now out on palliative care and hospice than there was back in the day. There's lots
and without cost.
Right. And there's new things to try. For example, one of the things I love to do and was done through reading years ago was Ira Byock's the 4 statements, and helping people, and you can look that up, but people who are navigating at end of life, who have perhaps a strained relationship, to be able to navigate reconciliation at end of life. That's a wonderful thing to do. It invigorated me to try new things. And so there's so much more, and research and best practices. What are you doing? How are you putting that into practice? So that's really basically competency 13.
And participate in competency 14 is participating in quality improvement projects and or research to increase your understanding of palliative care and the way that you provide palliative care and hospice. For many chaplains, this has arguably been the most challenging of the competencies, though we are beginning to see change in that. So we hope today even to demystify it a bit, to reassure you a bit, and encourage you to use a mentor as a very valuable resource, especially for this, as well as all competencies. So begin with the basics. Think about how much you really know about quality improvement theory, process, standards, and how much basic research education and opportunities you've taken part in. There may well be professionals in your organization and in our profession who will be happy to mentor and guide you. And it can be fun. If you've had some research and QI experience that resulted in actionable outcomes, that's what we want to hear. And we want you to also talk to us about taking it a step further, about what might be next. And if the outcomes of what you explored and what you tried to do were not what you anticipated or hoped for, well, there may be opportunities to explore possible next steps. And these experiences don't have to be, award-winning breakthrough projects. They're fun to read about, but you can start small. What's most important is that your project demonstrates your understanding of this competency and why it's so important for us to practice with research-informed interventions. And we'll be looking for you to show us how you may have adapted your project or your research study specifically to the needs of your environment and how you identified and utilized the resources that were available to you. If you've already done some of this, tell us the story. Talk to your mentor about it, from the source of your idea through to its completion. What challenges were there? What challenges continue to bother you as a chaplain? So think about how, where, and whom you're sharing with. What work makes you, what work in this area leaves you feeling encouraged? What makes you feeling discouraged? And when do you feel like you have an appetite for more of this? When does this light your fire? Going forward, think about what did you learn that could help guide you? And looking back, think about your efforts at collaboration. Have you identified colleagues or mentors that you can work with going forward? And what might that look like? So that's what we're looking for. The integration of the importance of this competency, which is probably the most relatively new one for chaplains.
And to just add, and Karen had mentioned it, you don't have to do an earth-shattering quality improvement project. For me, it's, and this needs to be a quality improvement project on your palliative care or hospice team,
Yes.
Not the bigger hospital at large. And for me, one example of one is, I wonder if patients' pain decreases if they have music at the bedside at end of life. I created, so I had a guitarist come in and a harpist. They played. I had 5 questions for the family member or the patient, if they were not actively dying, to fill out before and after. Did their mood change? Did they feel less pain? 5 questions, easy peasy. Did that for 6 months. Took it and then measured it. So the questions that we need to be asking ourselves in our team is there something we could be doing differently? Is there something we could be doing better? And go from there. Easy. It doesn't have to be a 50-page research project. Okay. So we want you to think about it in ways as your team and things that you can do better, or perhaps you're wondering about that could help. Okay.
Yeah. Our palliative physician brought her music therapist in, and when she extubated pediatric patients and measured that with patients that she extubated without music, And then that was the result of her research and the difference that it made for patients. So those things are just really, really important, but very simple. So we've
Jesse is asking a question, Karen. It's my thesis project was focused on burnout and hospice care professionals and how spiritual practice alleviate burnout. Would this apply to this competency?
Yes, it does. And so the more you can tailor it to your palliative team or get your palliative team involved with it. But yes, those are such big issues right now in the workplace. So absolutely. Yep.
Unless you're in hospice care and that's your focus.
Right.
So depending on where you are.
Good. So here we are back at the cairns. We've come to kind of the end of our journey together, although we certainly, I think, can answer a few more questions. But we hope that you have a better understanding now of readiness for advanced practice certification, and maybe even a greater appreciation for wanting to embark on this journey or not. Remember the image on this slide. These cairns were assembled along the shoreline. Think of these small piles of stones that are balanced like children's building blocks as creating a connection with one another as we travel the path of learning together, learning and growth in our profession, and learning and growth in this wonderful field of palliative and hospice medicine, and the learning and growth we experience as we strive to integrate these 14 competencies more deeply into our practice. Cairns exist because of the encouragement of those who have traveled the path before us. Sedona encouraged me on my path. They welcome us and they make sure we find the way. Cairns can be missed on the landscape when it gets rough and rugged, but cairns remind us when we're still on the path. We follow them, and where we can, we build a few of our own, and we make a contribution to the collective wisdom of our colleagues and our profession, and to the care of those who've been entrusted to us. Ram Dass, a spiritual teacher and psychologist and author, once wrote, "We're all just walking each other home." So to build cairns, to be a cairn for others, to be a certified chaplain, means finding our calling, knowing who we are at the core of our being, and then walking each other home. So thank you for inviting us to be with you today. And if there are any more questions, we'd be happy to entertain those as well.
We can start maybe with Virginia's and Brian's question and then go off to anybody else who had any other questions. So Brian's question was, when writing for this particular competency, is it more important to demonstrate knowledge of different types of grief or to have different strategies for ones that are identified?
So I'll take this one, Karen. You can take the next. So Brian, and everyone here, it's really crucial to know that the difference in writing between BCC and advanced practice. In BCC, we wrote to each competency, 1, 2, 3, 4. In advanced practice, it's all about integration and storytelling, as Karen mentioned before. So what we mean by that is you take a case study or two and you share this case study and you integrate and talk about how you demonstrated proficiency in the competency. So let's say you're gonna talk about the implications of medical treatment. So let's say you're using Susie as an example. I met Susie in the palliative care clinic, and you tell a little bit of story about that and talk about how you knew that it would be important for her to do it, or her advanced directives and her goals of care planning to get that done due to the fact that she has stage 3 at that time, breast cancer. And so you facilitated that conversation. And how did you facilitate that conversation? What did that look like? Take us in the room with you. If there's any way that we can explain it to you, it's always take us in the room with you through each competency. And then Susie was in the hospital, and then you demonstrate the other competency where her goals of care has changed. And then you take us into that room, and then you take us into the next piece of her story where there's a goals of care meeting and the family is there, and the family dynamics that happened, and how you intervened in that family dynamics, and how you intervened in helping the family. I call it we're medical translators. How did you translate what the physician was saying to the family? How did you lean into that? Take us into that room, help us to see the fullness of the picture. So do you see the difference between writing to each competency versus a story, and how you navigated it, how you took how you weave the competency in, and at the end of it, how you've done it all, except for the research. That's a different one,
Right.
when you can't weave in, but pretty much 2 through 13, you weave.
And it's not what you know, it's what you do. How you weave, how you pick up the strands and you weave them together and show us the story.
We
Yeah.
don't want head knowledge.
No.
We don't only want heart knowledge. We need them both, head and heart.
And then I believe Virginia's question was in regard, oh, you can go ahead if you'd like to say it. Go ahead.
Thank you. I wanted to ask, what is the actual process like? Is it an interview? Can you just tell us that, please?
So you send us all your materials, and then you are assigned a committee, and it really is you. So we will do similar to what you do with when you're first certified. The team does lift up some questions that might not have been clear for us, that we want to ask you to speak to, say a little bit more about. And so the focus is on you, again, telling us your story. If we feel that something wasn't so clear in the story, we know that you know a lot about this, but what did you do with it? We don't see you in the room. And so it's a dialogue. This is very much a dialogue. You telling us your story and why you believe that your competencies are at the level that you should be a board certified advanced practice chaplain in this field. Does that answer your question?
Is that on Zoom or in person?
Zoom.
Yes.
One thing Karen and I also highly stress, is to get a mentor. When you even begin to think about doing this, please consider getting a mentor, because if you have a mentor, your chances of success rise dramatically.
Yes.
And you can get a mentor from APC or NACC, because we work together and we collaborate, and everything, we interview together. So if you find that you're not successful in getting an NACC mentor, because we're smaller and sometimes some of us are busy, don't hesitate to get an APC mentor.
Yes, they're excellent.
Yeah, don't hesitate. It's not us or them anymore.
No,
it's
not at all. Yep. And they will be so helpful, all along the way, because as they see that, if they see your writing is kind of going off in the direction of leaving the story and trying to tell us how much you know, they can bring you back into your story. And then the writing really, we want to see you in your writing. We don't need another textbook.
Well, thank you. I think we're coming to the end of our time. We have 2 things to share. Karen and Sedona, just wonderful job. Thank you so much. That was very clear and helpful and very informational. So thank you. Really appreciate it. For anybody, if you have questions, we will put Anita Houghton's email down. It's just the certification email, but if you have questions, send them directly to her, and then she can facilitate emails to Karen.